الصراحة كلنا بنتعلم من العلم اللي هي بتيجي تقوله لنا، وانا عارفة ان الدكتورة صفاء قالت لها لازم تيجي تدي توك وهي الصراحة ما تأخرتش دكتورة سناء. هنستمتع النهاردة بالتوك بتاع الدكتورة سناء بعنوان Highlights on Atopy in Pregnant Women and Early Infancy.
بسم الله الرحمن الرحيم. First of all, I would love to thank my dear with Dr. Safa, colleagues, professors, daughters and sons for this kind of invitation to share in this prestigious meeting always. It was a very short notice, but it so happened that Safa called me just a few days ago and she asked me to present something from what I presented before. And I told her I never usually repeat myself, so there was a recent meeting in the American college that I just attended a few months ago, and this talk was like part of the talk was discussed in this. So the credit goes to دكتورة صفاء وزمايلي طبعا ان هم زنقوني في الاجازه دي. We thank you very much again. My talk today is about Atopy in the perinatal period. I have no conflict of interest regarding this presentation. And the aim of presentation is just to give you highlights on two topics or two areas of interest. The asthma in pregnancy, the implications on the neonate, as well as the non-IgE mediated milk allergy in the early neonatal period. Asthma in pregnancy is associated with complications. And this reflects the importance of taking history, maternal history, generally speaking, whenever you are asked to see a neonate. There are asthma control medications, considerations, diagnosis of asthma in pregnancy. Always there are restrictions in the diagnosis. Medication safety, which is the most important thing that I will discuss today. And then the treatment approaches based on the GINA guidelines that Dr. Adil will discuss by the end of the day. The complications of asthma in pregnancy. Asthma affects between 3 to 10%. It's a lot of asthmatics in the reproductive age in the US. Unfortunately, I did not find Egyptian statistics for that. And it's a good article if you go to the OBGYN hospital and check how many asthmatics there and how many on asthma medication, and this can be published in a Q1 journal. It's a lot of statistics that you can gain from the 4,000 deliveries a year at Ain Shams University. More than what you expect. The asthma, the severe and uncontrolled specifically, had been associated with increased risk of both maternal and perinatal complications. Preeclampsia is reported in asthmatics, and I've never seen like history, maternal history in those cases. Gestational diabetes, spontaneous abortion, preterm delivery, fetal growth restriction, and even congenital anomalies. The possible causes are well known: hypoxia and the use of asthma medications. Associated vascular and uterine hyperreactivity. So that tells you how to maintain the control is very important. If a mother is pregnant and she's asthmatic, and she will ask you, what is expected in the course of my asthma during pregnancy? One third. One third of the asthmatics can improve. 1/3 of the asthmatics can get worse, and 1/3 will stay stationary and can get worse to the extent that they require ICU admission. I have one of my patients who is on biologics, and she decided to quit medications because of the pregnancy. She ended up in the ICU twice. When is the timing for asthma exacerbations? If you look at the activity, the four curves there showing the use of medications, the activity, the nighttime symptoms, and you can see all of them in the highlighted box in the middle, and on the right side, the two columns between the 17th week of pregnancy to the 32 weeks of pregnancy, meaning asthma exacerbation rates increase in the second trimester and decrease during the last few weeks of pregnancy. Fortunately enough, nobody knows, maybe because of the delivery issues, maybe the mother will improve. Alhamdulillah, yani, this is something good. Can you predict asthma exacerbations during pregnancy. What are the risk factors for exacerbations of asthma during the pregnancy? And this is based on the meta-analysis of 35 publications. There are maternal factors, pregnancy factors, and asthma itself factors. The older the mother, the higher, the heavier weights, the cigarette smoking, black ethnicity, and anxiety and depression. And most mothers will be anxious and depressed whenever they are expecting a baby. So this should be taken into consideration. Pregnancy factor, interesting enough, not the higher pregnancy weight, the intrauterine growth retardation is associated with asthma exacerbations, multiparity and multiple pregnancies. The asthma factors, if the mother will give you a history of a previous exacerbation, the next pregnancy, you should be very careful in choosing the medications to control the asthma. History of pregnancy exacerbations, used of inhaled corticosteroids and decreased FEV1, forced expiratory volume in the first second, which reflects the severity of the asthma. Can you diagnose asthma in pregnancy? Yes, you can. And there are certain things that are contraindicated, and I don't think that they are doing it. At least at our unit at Shams University in the Children's Hospital, which is supposed to reflect children till teenage period, so a lot of pregnancy. There are safe lung function. The pulmonary function testing, the spirometry, which is needing active, and the plethysmography, or the body function, the total body function, both of them are quite safe. It's a lot of effort, but it's still quite safe. Can you use bronchodilators to diagnose asthma? Asthma, you cannot diagnose asthma simply like that. You have to you do a baseline lung function, give a bronchodilator, salbutamol, farcolin, whatever medication. Wait for 15 minutes, repeat the lung function, check 10% improvement in the FVC and FEV1. If you get this 10% improvement, it means that the patient is asthmatic. And this is how we diagnose asthma. It's exercise induced, get the patient, let him do the baseline FEV1, let the patient run for 10 minutes, usually in the morning, wear sneakers, and get the heart rate doubled, and then check the lung function at 10 minutes interval till 30 minutes after, and then give a bronchodilator. If there is a 10% improvement, it means that this is exercise-induced bronchospasm. There are certain criteria that we diagnose asthma in particular. Can we use exhaled nitric oxide? Inshallah, at Ain Shams University soon, we will have the exhaled nitric oxide machine, inshallah, with the next visit. You cannot do a methacholine challenge. Methacholine challenge is a standard dose to trigger asthma. And this is when you don't suspect it, or you have irritants, patient working in an environment with a lot of cigarette smoke, or working around factories, and they have asthma. It is triggered, so you can do what is called the methacholine challenge. The considerations of asthma, the majority of asthma medications can be continued with a shared decision making, and I will tell you shortly how to do that. And the problem with the all pregnants is that they don't want, if they are aware enough, they don't want to take even any medication because the risk for the infant. Two big categories. It's a busy slide, don't worry, I'm not going to discuss a lot of it. The first part of it is the bronchodilator, the salbutamol, albuterol. Pre-pregnancy, first trimester, second, labor, breastfeeding, this is the first one that is compatible. And by the way, the FDA had changed the pregnancy medications from A, B, C. That was the old classification, the medications that were done on animal studies or human studies in order to say that this medication is safe or not safe. It's not used anymore. So albuterol or salbutamol or farcolin is quite safe. How about terbutaline? If the patient is having severe asthma, and you have ICU patients here, if you use terbutaline, is it safe? Yes, it's probably safe. Those are considered short-acting beta agonists, SABAs. The SABAs, whether they are given to the mother or the fetus, you should expect tachycardia and hyperglycemia. Can be used? Yes, can be used, but excessive use should be avoided. So the first group, short-acting beta agonist, meaning you give them nebulizer, you give them Ventolin, whatever, like no trade names or whatever medications. Those are studied a lot with no side effects on the fetus. How about long-acting beta agonist? We have only two LABAs, salmeterol and formoterol. What is the difference? Seretide is salmeterol. Symbicort is formoterol. They are both long-acting beta agonists, meaning the effect stays for 12 hours. But the initiation of action is very short in the formoterol. It starts within 3 to 5 minutes. With the salmeterol, it takes 30 minutes to work. That's why the GINA guidelines said, what is the heck? Why giving albuterol alone? And asthma is an inflammation. Why not giving cortisone plus bronchodilator? And they decided that only formoterol, and this is actually started in Europe with the GINA, the Global Initiative for Asthma, earlier than the National Heart, Lung, Blood Institute, which is the American side. And the Americans are following the Europeans. And since I started my life there, America was leading in a lot, and it is declining, by the way. And Europe and hopefully the Middle East will, it turns in history. The European publications are a lot, and a lot of data, they are following it. And we are following the GINA guidelines there, most of the centers. So what about the LABAs? Then if the patient is on, as I said, on Seretide, what the guidelines say, salmeterol is preferred. Although, as I said, the GINA guidelines say formoterol. Then they said, if the patient was controlled on Symbicort, a shared decision making and keep her on the Symbicort. But the studies were done on the salmeterol because salmeterol came earlier. And all those are retrospective studies. They don't do studies on pregnancy. So they take the data, they analyze it. They did not find problems with the long-acting, long-acting beta agonist. Clear? Then let's go the second category of the ultra long-acting beta agonist. We don't have them here. But started to have the triple. Oh, thank you very much. Appreciate it. We have vilanterol and olodaterol. Those are ultra long-acting, meaning in order to have adherence, the medication can be taken once a day. We have one of them here in Egypt. There is something called the Breo, which is GlaxoSmithKline that use the vilanterol. It's albuterol, and the olodaterol is the Symbicort analog. It's a triple therapy. Are they studied in pregnancy? No. Don't give ultra long acting to pregnancy. How about LAMAs, muscarinic? Because the control of the bronchioles, whether cholinergic, this is the cholinergic, the ipratropium or the atrovent, there is minimal experience in pregnancy, and the high dose lead to toxicity. How about mucophenolate? That you will see, I'm sorry, a lot in the market. A lot of theophylline. If you have a child, a baby, newborn, they just describe it, this, take the history, with irritability, with tachycardia, with vomiting, please check if the mother is taking mucophenolate or not, if she's having any, for example, bronchitis or asthma in the last few weeks in pregnancy, and she has been taking this. You don't know what is the level of the theophylline in the infant, because the theophylline will have withdrawal symptoms. So the children should be monitored. And this is actually, yes, compatible, but as you see, they have side effects. How about steroids and montelukast? Montelukast is used a lot. Is it safe or not? I will tell you very interesting data. The steroids also, as I said, the steroids that they had been tried a lot are only two. beclomethasone, because this is an old steroid molecule, the becotide and the beconase, the old steroid molecule, and the budesonide, Pulmicort. Pulmicort has been studied a lot in pregnant women, and fortunately enough, you have a nebulized form and you have the inhaled steroid, and it is relatively safe in pregnancy, but use the lowest dose to maintain asthma control. But also, if the patient was on another form of steroids, like cyclosinide or mometazone, probably safe. Do you see that? But for my suggestion, for us, in order not to go into legalities, we switch it to Pulmicort right away. Once, and the insurance will approve, although it's expensive, but the insurance will approve it. Is it clear? Pulmicort is relatively safe in pregnancy. How about nasal steroids? Nasal steroids, everybody uses nasal steroids, and nasal steroids are over the counter. But interestingly enough, some studies showed intrauterine growth retardation. So even nasal steroids are you used to say that, but nasal steroids, yes, there is no increase in the anomalies, although it's nasal, but the studies shows intrauterine growth retardation. So be careful, no single medication. How about oral steroids? If you leave the mother without those bronchodilators, without the inhaled steroids, she's going to end up having asthma exacerbation and end up taking prednisone and prednisolone. But there is a threefold increase in the cleft lip and palate from the oral steroids given to the mother during pregnancy. So it's better to control with the lowest dose medication rather than to get asthma exacerbation. How about singular? Guess what? Some studies showed limb anomalies. Some studies showed limb anomalies. It's not like thalidomide, but singular montelukast is not safe. Don't say that, oh, I'm going to stay away from the steroids, let me use montelukast. No, no, no. So what do we do there? Usually, short-acting beta agonist plus Pulmicort. If the patient was on Symbicort, to tell you the truth, how about biologics? We now have biologics in pregnancy. The biologic, you know, the biologics are IgG, right? And IgG monoclonal antibodies are transported in a linear fashion the more the second and the third trimester where the blood supply increases. So the potential effect may be likely greater during the second and third trimester. For omalizumab, which is Xolair, and it's now available in Egypt like a lot, and it's approved with the insurance. This is the safest biologic, and no other data published on the other biologics. Still, there are some ongoing. They are encouraging, but if the patient is on Xolair for severe asthma, I usually keep them on Xolair. Sometimes I prefer to stop in the first trimester, and since the exacerbation appear on the second trimester, then start it from the second trimester. Stay away from the first trimester medications, especially in like high-risk patients. I hope it's quite clear this part of the talk. The second part of the talk is food allergies in the perinatal period. All of us will see mothers coming to you asking you, does my baby have milk allergy? From all the complaints, whatever. They will tell you this is milk allergy. And it's becoming apparently kind of common slogan. I'm sorry? Moda. Yeah, this is the fashion. There are, I'm going to talk about cow milk allergy, CMA at the end a little bit. I don't know, 10 minutes? Okay, have the presentation. I'm good. I'm on time. No, I had good studies for atopic dermatitis and sensitization too. Non-IgE mediated, I'm not going to talk about IgE mediated, but for you to say that the patient is having milk allergy, it means sensitization. It means that the allergy system started to know the protein in a bad way, meaning positive IgE, meaning positive skin test, meaning clinical picture. Puzzle, 3 pieces of the puzzle. 3 pieces of the puzzle. But there is non-IgE mediated proteins. And now, like, we see a lot of enteropathy. When you see in the biopsy lymphocytes, this is activation of the immune system. And it is called now enteropathy that comes with so many. If you read in the GI, I hope we have some GI specialists here, you will see a lot of issues in this field. Non-IgE mediated, the most important is the food protein-induced allergic proctocolitis. There is food-induced dysmotility disorders, and it's called GORD, and food protein-induced enteropathy syndromes, and food protein-induced enteropathy alone without the syndrome, and the eosinophilic esophagitis. Those are the most common non-IgE mediated. Are they common, or the functional disorders are more common? Functional disorders meaning mother coming to you with diarrhea, baby having diarrhea, having reflux, having constipation, having colic. Those are the most common complications in the children. They constitute 50% of the symptoms, and those are functional, not related to activation of the immune system. This is non-IgE mediated. It is a protein reaction to the protein, but not IgE. It's not IgE. You can trigger tumor necrosis factor. You can induce the immune system activation other than the IgE. So the prevalence is 1 to 2.2%, and in exclusively breastfed infants is 0.4 to 0.8%. What is the spectrum of the non-IgE mediated? The food protein, as I said, FPIs, the food protein-induced enterocolitis. And by the way, the food protein-induced enterocolitis is not only by milk. And it happened, I've seen patients with noodles, with chicken, with sweet potato given to babies at 6 months of age, and they end up in the emergency room diagnosed as gastroenteritis, severe gastroenteritis and dehydration. And most of them, they tolerated the food again. I've seen adults with FPIs who the adult that has been tolerating the fish and shellfish, and all of a sudden you eat it and you start having severe diarrhea. Not poisoning or scromboid reaction, but it is food protein-induced enterocolitis. So food protein enterocolitis can happen with adults and can happen with children. So the food protein-induced enterocolitis syndrome, eosinophilic disorders, food protein-induced enteropathy alone, without the syndrome, because this one is different than this one. This one you have tumor necrosis factor. This one you will have the symptoms without the Ig, without the eosinophils, and without the cytokines. You will have just lymphocytes. Food protein-induced allergic proctocolitis, and this is a common stuff that you're going to see. And food protein-induced constipation, FPC. And food protein-induced gastroesophageal reflux disease, FGORD. Is it food allergy or functional disorder? What are you going to do? What do you usually do? Huh? What are you going to do? Is it functional? Both are related to the proteins. Both are related to the milk. I always say cow milk is for cows, and we are not cows. So simply, they have a lot of ingredients that we don't tolerate it. But fortunately enough, the infant plasticity, and we used to say that avoidance, but it's a good thing. Blood in the stool, the enterocolitis, the proctocolitis, in exclusively breastfed versus then formula fed. For if exclusively breastfed, yes, it is possible. You may consider watch and wait treatment. If the mother comes to you with a diaper with red streaks, don't rush into action. Tell her to come next week. Don't rush into actions, especially if it's tiny, small streaks of blood. And because it resolves spontaneously in many breastfed, sometimes not. Sometimes I have to stop the breastfeeding. We used to say that nothing goes to the breastfeeding. We said, no, now even garlic, the milk with the mother eating garlic will smell garlic. But the first choice is be easy. Take it easy. Don't rush into decisions. If In formula fed, it is less common. Why? Why it's more common than the breastfed? Because the mother drinks the milk. But then there are two types of milk. But this one is one. Recommendation in the formula fed is easy. Short-term diagnostic milk avoidance. What is the accepted short-term avoidance? 2 to 4 weeks. Don't keep the patient on the avoidance for more than 4 weeks. 2 weeks avoidance and then re-challenge. Followed by reintroduction. Clear? Then how about the proctocolitis that we just said? It is a cell-mediated, meaning tumor necrosis factor in the distal sigmoid colon, triggered by food antigens and also viral infections. It could be the protein was safe, but it so happened that the child got viral infection that made the growing immune system confused, then started to react in a weird way. So that's why I'm saying, be patient, take it easy. What is the clinical picture? It's the first 3 months of life. Blood in the stools can be gross and can be microscopic. And generally, the child is healthy, well-appearing. Large amounts of frank blood and colic are unusual. Most commonly triggered are milk, but it can be triggered by soy, egg, corn, wheat, and just name it. Clear? Proctocolitis, be easy, avoidance, and challenge. Management, maternal milk avoidance versus watch and wait. And diagnostic elimination trial followed by reintroduction, therapeutic elimination, and the gradual initiation of the what's called milk ladder if the staying longer than expected. And I will tell you the milk ladder for the mother. If the mother avoids the milk, then she will ask you, am I gonna stop the red meat? I said, well, the chances of cross-reactivity is less than 10%. So we're not gonna stop the red meat for a while, and we're gonna stop the milk and see. If not, then I will stop the red meat as well. And when I reintroduce the milk in the mother diet, you have to introduce it like the Canadian ladder style. That I will show you in 1 second. The risk of ongoing bleeding may be associated with mild anemia, and the risk of the bleeding may predispose the child to develop real cow milk allergy, because you are introducing proteins to the subepithelial residing lymphocytes. What is the milk ladder? Have you heard of it before? Ladder? This is, for us as allergists, we use it a lot. Milk ladder is step 1, 2, 3, 4, meaning highly heated milk products, meaning changed protein structure. How this happen? When you put the milk in the oven for 30 minutes or 45 minutes, you denature the protein and you make it less allergenic. Muffins, cake, birthday cakes. So when you introduce the milk to the mother, produce it. She will ask you for how long. I will tell her, took it for 2 weeks first. Don't rush it in 2 to 3 days, like a week or 2. Then step 2, heated but not extensively heated. Waffles, pancakes, that heated stovetop heating. Then after that, pizza, because pizza, usually the cheese do not get heated very much and it stays thick. So pizza and boiled milk. Boiled milk usually few minutes. So this is step 3. Then finally, the step 4 is the real protein in the milk, like cheese, yogurt, ice cream, or milk, that they are minimally heated proteins, minimally changed proteins, and those you reach it by around 2 months of reintroduction of the milk to the mother in the safest way. يعني انت مش عايز المذر ترجع لك تاني تقول لك once ان انا اكلت اللبن رجع البيبي الاقي الدابر فيها ريد ستريكس تانية. فليه خلينا في السيف سايد. Reflux symptoms, the non-IgE, in a formula fed or a breastfed. Breastfed, much less common to be related to cow milk allergy. The guidelines do not recommend maternal cow milk elimination as a first-line therapy. If the baby is having a lot of reflux, mother will not stop the breast milk. But after failure, you may consider. Again, watchful waiting, be easy on that. If a patient, if the baby is formula fed and the baby is having atopic dermatitis, other atopic conditions, a trial of milk avoidance before PPIs. PPIs now are associated with increased food allergy. When you give a PPI, if you look at the microscope of milk in the stomach of a baby, you will see it digested in a very short time. If you give them proton pump inhibitors, the milk will stay as such, and the chyme will go to the intestine in big chunks, and then will be absorbed as big allergenic mass, and that is related to milk allergy. We used to give kids, remember the apnea of the children long ago, that was used a lot of reflux medications, Prevacid, and now they say what we did increased the food allergy. Apparently what we give to the kids made them worse. I'm done. Colics, this is like one last slide. Food allergy is unlikely to be the cause for colic. Reserve empiric short-term elimination in the maternal diet for infants with severe colic. The same, more strongly warranted in the setting of atopic children. Constipation in exclusively breastfed, no consistent association, and the recommendation against maternal milk avoidance. What is the dietary management? As I said, 2 to 4. And what is the substitute? This is the last slide. Those are the recent guidelines published April 25, whether the World Allergy Organization or the other SPGAN, everybody. First choice, extensively hydrolyzed formula. Do not give amino acid formula to prevent a food allergy in a child. As you can see, all of them, hydrolyzed rice formula versus extensive hydrolyzed formula versus rice formula, then amino acid formula or hydrolyzed rice, and the amino acid only is even reserved for severe cases. The third choice is soy. Soy should not be used before 6 months of age, or they say if you have economic issues, you can definitely use soy. And this is the article and summary. Non-IgE is very rare in breastfed infants. Diagnostic elimination 2 to 4 weeks, minimize the risk of the therapeutic elimination diet. Forget about this, and thank you.
As usual طبعا محاضرة يعني ثرية جدا full of questions. وضحنا حاجات كتير قوي، بس طبعا كلنا دماغنا فيها اسئله كتير دكتوره سناء، فمش عارفه. اوكي نخليها في اخر السيشن. طبعا اشكر دكتوره سناء على المحاضره الثريه جدا الابديتد از يوجوال. اشكر جدا دكتور عادل، دكتور هشام، والدكتور محمد البربري، والدكتور خالد العتاوي على الدعوه الكريمه، وطبعا الاليجنت ليديز دكتوره صفاء، دكتوره غاده، وذا رانياز. ايوه لا دفعتي واصدقائي واصحابي ذا رانياز. واقدم دكتوره نرمين حسين عمرو، استاذه الدكتوره نرمين هتقدم لنا البوست ناتال مانجمنت اوف دي اس دي ذا هوليستيك ابروتش. اللي هي دكتوره نرمين استاذ طب الاطفال كليه الطب جامعه عين شمس، واستاذ الغدد الصماء one of the pillars of pediatric endocrinology clinic في الدمرداش. طبعا شهادتي مجروحه ان هي بالسينيور بتاعي وصاحبتي وبتعلم منها كتير. واي بروميس اول اوف يو بمحاضره ثريه جدا.
مساء الخير. طبعا في البدايه احب اشكر اساتذتي استاذ الدكتور هشام واستاذه الدكتوره صفاء على الدعوه. دايما انا لسه بقول انا بعتبر نفسي one of the members of the neonatology unit لان انا ابتديت فيها، وبعتز بكل زمايلي. Thank you very much for the invitation. I'm going to try to give you